This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti or Waitangi partners.
This episode is not sponsored by any pharmaceutical companies. Our aim is to deliver balanced, evidence-based discussion. When medication is mentioned, we'll use the generic name unless referring to a medicine listed on the PBS, in which case we'll use the commercial name. Please note that availability can vary between Australia and Aotearoa, New Zealand. Welcome to Talking O&G, a RANZCOG podcast. In each episode, we take a closer look at key RANZCOG guidelines, ANZCOG research, and other essential clinical resources through in-depth conversations with leading experts from across Australia and Aotearoa, New Zealand. I'm Associate Professor Scott White. I'm a maternal fetal medicine specialist based in Perth, Western Australia. Today, we're unpacking RANZCOG's updated clinical guideline on prenatal screening for fetal anomalies, a topic that sits right at the heart of everyday antenatal care. There's a lot for clinicians to consider, from first-line screening options to structural ultrasounds, diagnostic testing and post-test counselling. To guide us through it, I'm joined by two expert clinicians who helped shape the new guideline, Professor Lisa Hui and Dr Lilian Downie.
Hi, I'm Professor Lisa Hui. I'm a maternal fetal medicine specialist with an interest in fetal medicine, genomics and prenatal screening. I had the pleasure of chairing the guideline development group that wrote the guideline we're discussing today.
I'm Dr Lilian Downie. I'm a clinical geneticist working in prenatal genetics and newborn screening, also based in Melbourne, and I was a member of the guideline development group that Lisa chaired.
Thanks both for joining us. Before we get into our clinical conversation, can I ask that you both declare any relevant conflicts of interest? Lisa?
I have no conflicts to declare.
Great, thanks. Lil?
I'm working at the Victorian Clinical Genetics Service, which is a laboratory that offers some of the tests that we'll be talking about today, but in a clinical salaried position.
Great, thanks. So, Lisa, this guideline brings together several previous RANZCOG statements into one document. What was the thinking behind that consolidation?
Well, we combined the four statements because there was a lot of overlap and duplication, and I think one guideline really acknowledges the continuity across screening and diagnosis and the interrelatedness of genetics and structural anomalies. Mm-hmm. So we hope to put it all together into a one-stop guideline for clinicians.
So let's start by discussing the first recommendation, one that really anchors the rest of the guideline. The Guideline Development Group recommends that all pregnant women should be provided with information and have timely access to screening tests for fetal chromosome and structural conditions. Lisa, why was it important for the Guideline Development Group to lead with this good practice point?
Well, we felt that clinicians should be reminded that prenatal screening should be offered to all women, regardless of their age or any assumptions about their attitudes to prenatal screening. It remains common for clinicians to assume that the value of prenatal screening is tied to a woman's attitudes or preferences about abortion, and we wanted to remind clinicians that there are actually a lot of clinical advantages as well as psychological advantages to knowing if a baby is going to be born with special health conditions. I usually frame screening as an opportunity to learn more about a baby's health and development before birth. And if a woman declines screening, I try and gently explore her reasons for declining and just make sure she's informed of the potential benefits before we close that offer. Yeah.
Non-invasive prenatal testing, or NIPT, has become the preferred option for aneuploidy screening for many couples and is now widely used in many clinical settings. How does the updated guideline compare NIPT with combined first trimester screening, and what does the guidance now offer on how to choose between those two?
So this guideline differs a little bit from the former version in that it clearly positions NIPT as the preferred option to be discussed with women because there's now a wealth of evidence showing that it's superior in its accuracy, both in its sensitivity and specificity. However, the guideline does acknowledge that there are significant access issues because NIPT doesn't receive a Medicare fund, any Medicare rebate. So although it is the most accurate test, we are all too aware that it's not affordable for everyone. So for the first trimester combined test is recommended as the alternative if NIPT is not going to be suitable for that particular person.
So building on from that last question, with NIPT options now more widely available, what does the guideline say about screening for conditions like sex chromosome aneuploidy, like rare autosomal trisomies? How should clinicians approach offering and counselling for these optional extras?
I think the really important part of that, Scott, is just the counselling. So just really important to have a conversation with patients about what the tests that we're ordering does offer and what kind of results they can get back from that. So the test is most sensitive for conditions that I guess patients are most aware that are being screened for, like Down syndrome and the common trisomies. But many or most now also report sex chromosome aneuploidy. So I think many patients have the misconception that they're just finding out if their baby's male or female, but they can also get results back about more mild sex chromosome aneuploidy conditions that can be quite unexpected and difficult to manage if they haven't thought about the possibility of those things. Similarly, some of the tests also offer a look across the whole genome, so they might pick up smaller chromosome copy number variation, and that brings with it, more complexity that we could be detecting things that are just in the placenta and not in the baby, confined placental mosaicism. So I think the take-home point there is just clinicians need to be aware of what the specific test they are ordering, what kind of results they can get back, and making sure their patient has some awareness of that.
Yeah, of all the testing that we do, pre-test counselling is particularly important for this. Right. Often we find as people who come with abnormal results that actually they didn't even realise what they're being screened for, have no idea what that condition is and what it means.
Yeah, exactly.
Yeah. So Lisa, the updated guideline now recommends 2 key structural ultrasound scans, one in the first trimester, say 11 to 14 weeks, and one in the second trimester, 18 to 22 weeks. What's the rationale between offering both of those scans and how do they complement each other in clinical practice?
The 11 to 13-week scan was originally introduced as the nuchal translucency scan, so as a component of first trimester combined screening. Now that NIPT is a much more common option for people for aneuploidy screening, we still wanted to emphasise that this should be offered. We now recognise that that scan has an independent value for detecting structural anomalies. A good first trimester scan will detect at least a third of major structural anomalies and up to 90% of lethal anomalies such as anencephaly. So there are many clinical and psychological benefits to an earlier diagnosis of these sorts of conditions. So that's why we wanted to ensure that women still had this option to have an early diagnosis. The 18 to 22-week scan is still essential, of course. The first trimester scan is not a replacement for the second trimester morphology scan because there are many anomalies that aren't detectable in first trimester. So when combined, these 2 scans provide the maximum detection rate for women and the greatest clinical benefits.
The Academy of Clinician Educators from RANZCOG is here to help you grow your skills and confidence as a clinical educator. As a member of ACE, you'll get access to professional development, teaching resources, mentorship, and a supportive network of clinician educators across Australia and Aotearoa, New Zealand. Discover practical tools you can use to develop your skills in core areas of teaching in medicine. RANZCOG trainees, affiliates, proceduralists, fellows, and pre-vocational obstetricians and gynecologists are all welcome to join. It's free. Visit ranzcog.edu.au/ACE to learn more and join today.
Lil, if someone has a high chance result on combined first trimester screening or an ultrasound finding suggestive of a structural fetal anomaly, is there still a role for NIPT or should we recommend going straight to diagnostic testing like CVS or amniocentesis in that situation?
So I think the important thing there is counselling and addressing what the right testing pathway is for that family. Diagnostic testing with CVS or amniocentesis will give us the most accurate result, but for some families the risk of complication or miscarriage is not acceptable, and in that setting NIPT can be used for a more sensitive screening test.
So Lila, there are situations in which, say, somebody has a high probability screen for a particular chromosomal abnormality and they've got suggestive structural features for that abnormality on ultrasound. Is there ever a situation where you might say that diagnostic testing is not necessary?
Yeah, so I think in that situation, some families will choose to make decisions, based on abnormalities detected on ultrasound, and particularly if that's concordant with a high screen result, that might be sufficient for decision making. We would still recommend diagnostic testing even after, ending a pregnancy in that situation, and we would also offer, for more certainty, a diagnostic test, prior to decision making as well.
Lisa, talk us through a clinical decision point here. So when you're choosing between CVS and amniocentesis, what helps guide that decision? And is it mainly about timing, or are there other factors that you'd consider?
Yes, there are several things to consider. Chorionic villus sampling, or CVS, can be done earlier at 11 to 14 weeks. And if someone has a high chance result from screening, at 11 weeks, and waiting longer is often not very helpful. Amniocentesis can be done from 15 weeks gestation. The literature on the procedure-related risk of miscarriage of the two procedures is very complicated, and there are lots of methodological differences in how the studies were conducted. And so the guideline development group looked at the literature and concluded there wasn't a single risk figure that we could give for each of those types of procedures, and that on balance the risk of miscarriage was not substantially different between those two procedures, and that really the choice of procedure should be based on the clinical circumstances, the patient's preference, the clinician experience, and the availability of those procedures.
Mm-hmm. And does the nature of the result, the specific condition that someone screened at increased chance for, does that influence your decision?
Yes, that's one of the things that needs to be considered. So there are situations where you may, as a clinician, feel that there's a higher chance of confined placental mosaicism, and in those circumstances women need to be informed about the chance of perhaps needing two procedures to clarify exactly what's going on with their fetus. If they have a CVS that returns a mosaic result, they may be advised to have an amnio. So there are specific circumstances in which that might be recommended, and so having skilled post-test counselling is important, particularly after an NIPT result. Yeah.
I think that issue also highlights the importance of having the early 11 to 14-week ultrasound in combination with NIPT, if that's what a patient has chosen, because those tests can be used to help be interpreted together. So a high-risk NIPT with a normal ultrasound might lead us to recommend an amniocentesis because the risk of confined placental mosaicism is higher. Whereas if there are supportive features on the ultrasound, we might be quite comfortable doing that earlier test. So they really need to be interpreted together.
Yeah. And Lil, are there situations where you might see a high chance result on NIPT combined with structural anomalies on ultrasound where perhaps diagnostic testing is not even required?
I would say no, there's no situation, there's very few situations in which we wouldn't recommend diagnostic testing for that extra degree of certainty, because it really, NIPT is very accurate, but it is a screening test. I think, again, it's about counselling and patient preference and access issues sometimes, but I think the bottom line is we would always recommend that more certainty in diagnostic testing.
Lisa, equity is a key theme in the guideline. What barriers still exist when it comes to access to prenatal screening, especially in Australia for First Nations women and for Māori women in Aotearoa and New Zealand?
Yeah. Late presentation to care, geographical isolation and the out-of-pocket costs can provide major barriers to accessing best practice. Particularly ultrasound access is inconsistent across rural and remote areas, and that really affects timely diagnosis and follow-up. So there is a clear need for culturally safe and accessible and respectful care, and we know that our current practice aren't spread evenly across Australia and New Zealand. And one of the major issues in trying to advocate for better access is a lack of accurate data to kind of make these cases to policymakers for improved funding and services.
So given those challenges, does the guideline offer any practical strategies that clinicians can adopt to help improve access and equity in their day-to-day work?
Yeah, so I think, to start off with, clinicians should remember to offer screening to all women without making too many assumptions about their background, but, offering it in a culturally safe and respectful manner, and normalising screening as a routine part of care and as an opportunity to learn more about a baby's health before birth is a way that I think is a safe and sensitive way to offer it to everybody. And I think if screening is declined, we should be responding with curiosity rather than just moving quickly on and making assumptions about that a woman's made an informed decision. We should make sure that we dispel any misconceptions and make sure that that decision is truly informed.
Lil, when prenatal screening results are complex or unexpected, who's best placed to deliver that post-test counselling, to deliver the results and provide the explanation of what it means? And what does good counselling look like in that context?
So I guess in the ideal world, someone who's experienced in giving back those results. So as Lisa said, in this metropolitan sort of setting, we're lucky enough to have multidisciplinary clinics with maternal fetal medicine specialists, genetic counsellors, clinical geneticists, and that's sort of the gold standard. In other settings, it might be a trusted clinician who's got access to a genetic counsellor. That might be remotely by phone, or it might be a telehealth appointment. But someone who understands the test result and understands clearly what the next steps for the patient should or could be is the important aspect there, I think. Mm-hmm. And there's a range of complex results that might come back that might have different follow-up requirements or issues with interpretation. We touched on some of them before with NIPT and that risk of confined placental mosaicism and that requiring the need for maybe differentiating between CVS and amnio. But similarly, we might get back microarray results after those invasive tests that have variants of uncertain significance with a lot of uncertainty for patients. So someone experienced in counselling around that uncertainty and knowing what those tests mean and how we might be able to clarify things further for the patient is important.
Yeah, I guess one issue that you've hinted at there is that so someone screens at increased chance for one test, and in offering the diagnostic testing for that, we might uncover other options depending on what genetic tests we actually do.
Yeah.
So I guess that's needs to be part of that post-test counselling, as well as not necessarily what we might go looking for, but what else we might find as a side.
That's right. I guess the counselling ideally comes as a package, the pre-test and the post-test. So patients have some idea of what kinds of results they can get back, and that might include things with the high level of uncertainty, and have already started thinking about whether they want that testing and secondarily what they might do with that information if it is that uncertain or complex result.
Before we wrap up, Lisa, Lil, what's the one key takeaway you'd like listeners to remember from this guideline? Lil, let's start with you.
Thanks, Scott. So the move toward NIPT as a first-line screening test really reflects the evidence that it's more accurate and sensitive, but the guideline continues to advocate that we need to address access and equity for all women across Australia and New Zealand. And I guess the follow-up point to that is that all patients should be offered screening and supported in their decision, making sure that's informed.
Every woman who's interested in prenatal screening should be offered NIPT or a first trimester scan. And we should be improving the evidence base on prenatal screening and utilisation so that we can advocate better to improve access for all women in Australia and New Zealand.
Yeah, thanks, Lisa. Lil, thanks for your insights today and for your great contributions to this guideline. It's been a really informative conversation. And thank you to our listeners. If you found today's episode helpful, please rate, review and subscribe. And why not share it with a colleague? It's a simple way to help others find Talking O&G. And don't forget to log this episode for CPD. You'll find a form linked in the episode show notes, along with a link to RANZCOG's Prenatal Screening for Fetal Anomalies guideline. We'll be back soon with more expert conversations shaping obstetrics and gynecology across Australia and Aotearoa, New Zealand. Until then, thanks for listening.